In this section, I'm going to be talking about what I call the mainstream methods in qualitative evaluation. I suppose what I mean by that is that these are the methods that I most commonly use, and I think they're ones that are most commonly used by my colleagues in undertaking qualitative evaluations. So I'm going to start by talking about document review, and then say something about direct observation, and then a variety of interview techniques, focus group discussions, and then I'm going to think about a couple of rapid appraisal methods, an example of visual description, and an example of the kind of analytical activities that you can undertake in rapid appraisal mode. So if we start by thinking about document review, absolutely essential activity in any evaluation, very easy way to acquire information, and one which is often not done very well. There may be a range of documents which are relevant to you, which are either internal to the implementation that you're evaluating or external. This may be part of the routine data system or government policy statements, anything which is not specifically generated as an internal document of the particular implementation. And these documents can be in hard copy or digital form. So I'm including in document review all those databases that might exist on patient records and so on. So we can think about policy statements by governments which may influence the context within which the implementation takes place. There will be regulations with which the initiative has to comply, which health service providers have to comply in theory. There will be various reports produced by the intervention itself, or maybe reports produced by other people about the intervention. There will be records maintained both inside and outside of the intervention. There will be protocols. Again, these may be protocols developed by the ministry, which people are expected to comply with, or there may be protocols developed within the intervention itself. It's always good to look at the original funding proposal. What did the people doing the implementation say they were willing to do for the resources that were going to be provided to them? Then there may be such things as meeting minutes, workshop notes, presentations, and so on. There could be newsletters put out by the intervention. There could be media reports, write-ups in the newspaper as to what the project involves, or maybe appearances on television by members of the implementation team. Publicity materials put out by the intervention in order to explain what people are trying to do to the intended beneficiaries. Why are we doing document review? Well, there are multiple purposes. One is that it's the easiest way, apart from talking to the implementation team, of getting a basic understanding of the intervention, the implementing agencies themselves, who they are, and the context within which the intervention is taking place. So we can sit and we can read and we can try to understand who these people are, what it is they say they're doing, what the context, socioeconomic context, environmental context, health systems context within which they are trying to implement this intervention. Key area from the point of view of the evaluator is to say, well, what did these people say they were going to do? So the comparison between the intervention plans, including the timetable, resource use, and so on, with the actual implementation process. Are they on schedule, behind schedule? Have the plans changed? Have they been adapted? If so, are the reasons for adaptation, have they been given anywhere? Has anybody explained why the original intentions have been modified? Documents will also contain fairly basic quantitative data, give you an idea at least of the scale of the operation, the type and the number of intended beneficiaries, the number of people engaged in the project, the types of personnel, the health providers, the officials, the M&E staff, some idea of the intervention costs, how much of various components cost, which is the most expensive component of the intervention that is being undertaken. All to provide you with the context within which you can design your evaluation framework. And perhaps most crucially, it's the development of data collection tools. The document review should give you a reasonably good start in formulating the questions that you want to ask, the big questions. What are the key areas you feel the evaluation should focus on? What are the key questions under each of those areas? So we can use the background information from all these documents, from all this data that may be available, in order to put together some idea as to what the focus and intention of the evaluation process is going to be. First of all, you have to find out what documents exist. This can be quite an interesting exercise in itself. In a lot of projects, it is far from clear. There are lots of documents listed as being produced which don't appear to exist. A lot of records that are meant to be maintained which are not actually maintained. So we often find that there are meant to be clinic records, but there aren't any clinic records. People just are not keeping these records and so on. So the first stage is to find out what documents and records actually exist, and try to think how those map into your evaluation questions. Now, one key area here will be the documents which are specified within the original log frame, for example, of the intervention as intervention outputs. What did the team who are implementing the intervention promise to produce? Have they produced those? Those documents should be of reasonable quality. They're the ones that the implementation team promised to deliver. Having listed the various documents and records that you might want to examine, you'll then have to determine the accessibility of those documents. Where are they? Where are they located? What form are they in? Are they in digital form or a hard copy form? Just as an aside, in recent years, the digital camera has transformed the possibilities for getting copies of documents which are only available in hard copy for patient registers and so on done at clinic level. And if nobody objects, it's now become quite easy to capture images of documents even in very far-flung locations, as long as you can read the handwriting of the people who are producing them. You want to identify the documents and then work out which ones are really important and pursue the ones that you really need to get hold of. So determine the accessibility and devise a strategy. A strategy means prioritizing some documents over others, going to higher authorities if you need to get hold of documents that are maybe hidden away somewhere, maybe in offices that you don't have access to, and so on. And you also need some sort of timeline. You want to tie in your document review with the development of your evaluation procedures. You also want to find out as much as you can about how and why the documents were produced, because just having documents is not much use unless you can assess their value, unless you know how reliable they are, how accurate they are. And knowing why they were produced can be a great advantage in that. If they were produced simply to satisfy the requirements of the Ministry of Health, and you know very well that nobody at the Ministry of Health ever looks at those documents, and that's not an uncommon occurrence, then you know that the information in those reports, which are produced merely as a matter of form, is probably not that reliable. If they're produced in order to earn bonuses, if there's an incentive scheme which requires people to produce certain kinds of reports on certain kinds of dates, then probably those reports will be produced, but again you might wonder quite a bit about the quality of the information if they're being produced simply to tick the box to gain an incentive payment or a bonus. So you have to try to assess the accuracy of those documents. You can use your best judgment as to the likely reliability and accuracy of the documents, depending on what they're used for and how they were produced, why they were produced. But the other way you can do this is by triangulating with other documents. Do expenditures match up to patient numbers, for example? Is there any relationship between expenditures and the flow of services delivered? Do things match up with each other? Do the drug supplies and drug distribution, does that map into the number of patients which are coming and presumably being provided with those drugs? And of course you'll interview the project personnel and talk to them about the documents, confirm information, check what happened at meetings against the meeting minutes, and so on and so forth. Documents generate a huge amount of information, like most other qualitative exercises, and therefore you want to start thinking at a fairly early stage about how you're going to summarize the information. And the best way to summarize the information is to have a fairly clear set of evaluation questions. And as you're going through the forms, you do two things. One is that you try to map the information in the documents to the evaluation questions. And then you also think about, are there other evaluation questions which are arising out of the documents which you hadn't thought about before, but which are clearly of importance? And then you have to revise and have an iterative loop in order to map the documentation into your final list of research evaluation questions. What are some of the advantages and disadvantages of using document review as a way of thinking about evaluation? Well, it's relatively inexpensive, only using your time. You're probably quite an expensive person, but it's only you sitting at a desk with a report in front of you. It's unobtrusive. It doesn't get in the way. You can do it back at your hotel. It's non-threatening. You're not challenging people. You're simply asking for documents. Some of those documents may, of course, be very sensitive, and they may not want to give them to you. But if you can get hold of documents, then you can just sit and read them. You don't have to challenge people about their contents. People often don't realize what they're giving you. People often don't realize that when they hand you information in documents about patient numbers or drug allocation, that you will put the two figures together and cross-check them, and that could be quite risky for somebody who is stealing drugs, for example. They're a primary source of contextual and background information. Other than talking to people, this is your way into the context and the background within which the intervention has taken place. And that will guide you as to the possible constraints and bottlenecks that may have influenced the implementation. And they may raise issues which have been neglected. When you read the project proposal, you may say, there was a long section in the project proposal which talked about making the service, for example, accessible to the very poorest. And you may then start wondering, well, there's no evidence from anything else I've read that this has actually happened. You then raise that issue with people in the project and ask about, well, what happened to this commitment to the very poorest people? Has that gone by the wayside as you've become involved in the implementation process? Disadvantages. Well, information in very many interventions is very disorganized. People don't worry that much about keeping nice filing systems. So it can be disorganized, it can be unavailable. You may not be able to track down the documents. It may be incomplete, it may be out of date, and so on. So you don't find, in most places, really well organized filing systems of information, and it can be quite tricky to sort out what exists, what's available, and where to find it. There may be biases due to selective filing of information. Maybe those very sensitive reports are not actually in the same cabinet as the routine reports of the intervention. Maybe they're locked away in somebody's safe, or maybe they've been quietly disposed of somewhere. The information in the report may also be incomplete or inaccurate for the various reasons I've talked about, and the process can be very time-consuming. It's time-consuming, but it's probably time well spent in most cases. If you can skim read fairly quickly through masses of information, you can very often pull out the bits that are interesting and important, and put together a really good background picture of what is going on. Okay, having done our reading and working our way through the documents, we form a picture of what we expect to see, what we expect to find. We know what should be going on out in the field, and one way in which we can decide if that really is happening is through direct observation. So we can note if facilities are clean, for example. We can notice if staff are present on duty. We can notice if equipment which should be available in facilities is there, and we can sometimes notice if it's likely to be working or not, or broken, or got a sign on saying out of action. We can observe various processes. So we can sit in a facility and watch patients coming in, and we can see how they're being treated. We can see what their response to being treated. We can see how long they sit and wait to see a provider. We can observe various events. We can, if we're medically qualified, which I'm not, but then I work with medically qualified staff, we can observe a consultation. We can see whether a consultation is done properly with due regard for the well-being of the patient. We can observe a vaccination. I can well remember looking at, watching vaccinations which were carried out by what were called assistant nurses, where the vaccination was entirely mishandled and the child injected in entirely the wrong part of the body. So that gives you a fairly clear idea that things are not as they should be. And favourite again among my students, the idea of participant observation. I haven't done very much participant observation, and but the most interesting one that I actually took part in was assisting with. I offered to assist with stock taking in a medical school, and I learnt a lot that day about the process of drug arrival, storage, cataloguing, filling in the various forms, and doing the accounts. I probably learnt more than people hoped I would learn about the operation of that medical store by helping them do the stock taking. What are the advantages and disadvantages of observational methods in evaluation? Well, there are a number of advantages. In some sense, it's real, it's happening, it's real-time data, and you're watching things as they occur. And if you're a good observer, if you're a diligent note-taker, if you're careful about how you merge into the background, if possible, then you can have some faith that what you're looking at is what usually happens. You can get an impression of the way in which things work, how careful people are, how attentive people are, how courteous people are, for example, to incoming patients, how diligent people are in filling in records, and so on. Sometimes it's quite a good way of gathering information on individuals who are quite difficult to question. For example, drug sellers in a market. Simply by watching the activities of drug sellers and the kind of commodities that are being purchased, the kind of money that's being paid. If possible, try to overhear conversations between drug sellers and purchasers. You can get a reasonable idea of what's happening, what's going on, what the nature of the transaction is, even if the people on the other side of the market stall would be rather reluctant to talk to you openly about what is actually happening. So you can do some detective work, if you like. I have been in the process. I've been in a situation where I've sent people undercover to go and buy drugs from drug sellers, and they report back on the observation that they're undertaking. Another form of observation, but by somebody I've sent in undercover. Above all, we have great faith in direct observation as opposed to reported behavior. When people tell us how they undertake a consultation, when they tell us how they undertake a vaccination, that's okay. That means they have the knowledge of how it should be done, but we're only really convinced when we actually see it being done on a regular basis. Disadvantages are things to look out for in observation activities. Firstly, you can get observer bias, so that, for example, if you ask doctors to observe the activities of doctors, or nurses to observe the activities of nurses, your observers may well be sympathetic to the people they're observing. The nurses in my example know that nurses in rural clinics have a really hard job. They're underpaid, they're overworked, they have to do other things on the side to make a living. They feel sympathy for them. They may well overlook some of the things that nurses do that they really shouldn't do, and they may make assumptions about the good behaviour which they haven't quite seen but feel they should have seen. So there are questions about who is doing the observing and what it is you're seeing. On the other hand, if you go into, for example, a market, and you assume, if you start out with a hypothesis that all the drug sellers are basically criminals who are taking money under false pretenses from gullible customers, then you will probably see that. People often see what they expect to see. There's a lot of research evidence that people will see what their preconceptions lead them to think they should be seeing or will be seeing in any given situation. So you have to be careful about the biases that may be introduced into what seems like a very simple act of observation. There is the famous Hawthorne effect, that when you watch somebody doing something, their performance will be improved. Well, that's kind of what you might expect. It does mean that if you see rather poor performance by, for example, a health provider, you can be pretty sure that that's about as good as they can manage. The Hawthorne effect may have actually brought up their performance, but not to a level where it's satisfactory. That's quite an interesting way of thinking, I think, about the Hawthorne effect. One limitation of observation is that you can see things happening but have absolutely no idea why they are happening. You see money changing hands, but you don't know why money is changing hands. In China, for example, it is very common to see patients handing over money to surgeons. If you interview those patients, they will absolutely deny that this is any form of bribe. It is a way of trying to ensure good luck during the surgery. By giving a present to your surgeon, you bring good luck upon on the surgery, and that will hopefully produce a better outcome. So they would absolutely not see it as a bribe to the surgeon. They would see it as a gift which they are making in order to bring down the wishes of deities upon the surgery they're about to undertake. So we don't see that in just observing the handover of cash. It can be very time consuming and expensive. I remember years ago doing surveys in rural areas of Nigeria where the facilities were extremely underused. You might have 2 or 3 patients a day, and stationing a qualified doctor to sit at a surgery and essentially sit there most of the day, probably observing for 30 minutes at the most, because very few people arrived, was a very expensive operation. It wasn't quite clear how to get around that, but it can be quite expensive if you're using qualified people, and in health interventions we're often using highly qualified people to do our observing. They can spend a lot of time inactive, and that can be quite expensive in order to gather very little information. Let's move on to interviews, which are probably the most common way in which we gather information as qualitative evaluators. Various different types of interview that we can undertake with different kinds of people for different purposes. So very common to see the phrase key informant in proposals to do evaluations. And by key informant we mean individuals with a special knowledge of a key issue. So we may be talking about a policy maker, or the head of a hospital, or the head of an insurance scheme, or somebody with detailed inside knowledge as to how something is meant to work, how certain processes are meant to be undertaken. We often distinguish those from in-depth interviews. They may look rather similar, but here the purpose is a little different. And usually here what we're trying to do is to gather information from representative members of some stakeholder group. So we might talk to a group, we might talk to volunteer village health workers, for example, and we might talk to a number of those, and we're hoping that by talking to a number we're picking up the views, the attitudes, perceptions and so on of representative group of village health workers. So the idea is to build up a picture of how village health workers think and their attitudes in this case, as opposed to talking to our key informant about how processes are meant to be undertaken, how procedures have been developed, how policies have been implemented. The most popular form of interview, at least with my students, focus groups. The idea of getting together a group of people and then letting them exchange information, drawing out ideas from them. You can also have community meetings where you go into a village, for example, for the first time, and you both explain what it is you're hoping to learn by visiting that community. And you're also getting feedback as to what the community would like to tell you, how they might like to provide you with information, what their feelings are about the activity that of which they are the intended beneficiaries. A technique that I've become quite attached to are what I call personal narratives. So healthcare seeking narratives. People with, for example, long-standing conditions with chronic illness, talking about the way in which they've tried to seek treatment, maybe going through many stages before they find somebody who could actually diagnose their condition. I've worked quite a bit in Cambodia, and in Cambodia, if you have diabetes, you can spend years and years getting treatment from people who claim to have medical knowledge, but completely fail to diagnose the fact that you have diabetes. You can spend an awful lot of money on treatments which only may alleviate your symptoms, but don't address your underlying condition, and that's true, obviously, in very many countries. The effects of serious illness. This is one I've worked on quite a bit, which is asking people, well, Okay, you had hypertension. What happened? Did you have to stop working? When you stopped working, what implications did that have for your household? Did other members of the household help you? Did you get support from your neighbours? So on and so forth. Just encouraging people to tell you what happened to them as a result of the illness, and whether a particular intervention, community-based health insurance scheme or whatever, actually provides support for such people, or whether the scheme kind of misses that group because of the complexity of the situation in which they find themselves. We also undertake interviews during other activities. This is particularly true in participatory, in rapid appraisal work. I said at the start I would try to avoid using the word participatory unless I really meant it. In rapid appraisal work, we do a lot of activities with community members, and actually one of the main purposes of that is to talk to people while you're jointly doing an activity, an informal process whereby people often tell you very surprising things, give you insights you hadn't really expected to find, because you're together doing something else. You're not in a formal one-to-one interview situation. So what types of interview can we conduct? Well, we usually list them under 3 headings, though there are various combinations of these that we sometimes apply. The first is that we can have a conversation, so we can go and chat to somebody. We can have a meal with somebody. In one exercise, we invited children to come to lunch, and then chatted to their parents while the children were having their food. It was good for the children, and it provided us with a lot of useful information in informal discussions around the dinner table. Topic focused, so where we have an interview guide and we list topics and subtopics, and we try to orchestrate the conversation such that it covers each of those topics and subtopics, not necessarily in any particular order, but we try to make sure that we've addressed each of the issues that we want to talk about. And then we can go to the semi-structured form. So it's rather like a questionnaire, but the questions will generally be open-ended. And again, we won't necessarily go through that document in the order in which we've listed the questions. We can jump about as the conversation flows. So one question may lead on to another. We try it again to make sure that we cover all of the topics in there, but we have a fairly clear idea of what particular questions we want to ask. So we'll be asking about, can you tell me how you were treated when you went to the facility? What kind of prescription did you get? That sort of thing, rather than talking about the broad topics that we would do in a topic-focused interview. So conversational interviews used to explore broad subject area. What do you think of the new insurance scheme that is designed to help poor people in this community? Respondents should be relaxed and encouraged to just give information. So most of the time, the evaluator should be listening, encouraging the respondent to provide them with information, give their opinions, personal experiences, and simply interjecting to try to encourage them to expand, to cover issues which they've raised but maybe not gone into in much depth. So hopefully on that you may find the emergence of issues which you hadn't really thought about before, and which may be important at least to that particular individual and maybe therefore to other individuals, or you may find underlying reasons for implementation problems. So it may be that you were assuming that the reason girls were not going to the clinic was because of religious constraints, but when you have this conversation, people actually come out and tell you, well, no, actually it's really because we can't afford to send them to the clinic, and we barely have enough money to send our sons, and we feel we don't really have enough money to send our daughters. So the religious issue may be a convenient way of avoiding the question of the cost of visiting the clinic. The more informal these conversations, the more skillful the evaluator has to be. It requires considerable skill. There's a high risk of interviewer bias. So the respondent will undoubtedly react to the particular interviewer that is undertaking the questioning, and unless that interviewer is very skillful in listening very carefully, in responding very carefully, in trying to draw out the respondent, you will get a very limited and very biased idea of what that respondent really thinks they will be reacting. So you have to think very carefully about matching the interviewer to the interviewee. You have to think about how the social status of the two is going to be perceived by the respondent, about how about the language which is being used by the interviewer. Will the interviewee respond in a particular way if somebody speaks a very refined dialogue or uses local words in the discussion and so on? So it's a very tricky discussion because it is unstructured. The more unstructured, the more difficult, and therefore the more skill that's required. Can be very time consuming because it's very hard to avoid discussion of what for you may be irrelevant topics, but which for the respondent are central to their particular interests. So they may tell you a lot about the school experiences of their children, or what their sons who are working in urban areas are now doing, which may have very little to do with the objectives of the interview, but which obviously these people want to talk about because you are a stranger. They have the opportunity to tell you all about the wonderful things that their children are doing, the difficult times they're having, even if that has nothing to do with what you originally asked them about. So it can be very time-consuming, very hard to keep on track. From an analytical point of view, the conversational interview is very difficult because you end up with a lot of information which is very difficult to compare from one respondent to another. They're giving you a lot of information about their very particular circumstances, and it may be very hard to pull out the particular comparative aspects, comparing one respondent to another. That's one reason why we often prefer a topic-focused interview. So here we have a series of topics about the availability of drugs at the clinic, the way the clinic staff tend to treat people, the costs of going to the clinic, and we're trying to run through these topics with the respondent, trying to draw out their views in rather the same way, but trying to pull them back when they stray from these particular areas to cover each of the topics. Interviewer chooses how to phrase the questions, so the questions may be listed in a very, be given in a fairly short form on the interview guide, but the interviewer will have the skill to phrase them in a way which is going to draw out the particular person they're talking to. And the interviewer can change the order of topics if it's natural to go from one topic to another and skip over 2 or 3 topics in between. That's fine. And the interviewer will decide how much time is spent on each topic, or at least try to, at least having spent a certain amount of time on a given topic, they will try to shift the interviewee away from that topic and onto one of the others. The aim is to try to cover all of the topics and all of the subtopics within a given period of time. So you don't want too many. It's surprising how long it takes to cover just 2 or 3 topics and subtopics in an interview. So all the topics and subtopics should be covered. It's it makes it very difficult if you have a lot of interviews which only are covering some of the topics you want to raise, because then you find it very difficult to compare between the various interviews across those topics and subtopics. It reduces the potential for bias to some extent, but there'll still be a lot of the interview which depends on the particular interviewee. On the particular interviewer. So the nature of the interviewer, and usually you have a team of interviewers carrying out these exercises. You really have to check what kind of information you're getting from different interviewees with different interviewers. Are you getting what appears to be an interviewer bias with emphasis on particular topics, particular issues being raised, because a particular interviewer is conducting the interview? So what we need is greater focus, and hopefully that means that if we don't allow the interviewee to digress too far from the main topics, then the time required to perform the interview should be somewhat shorter. Again, as we're covering specific topics, we can at least compare responses from different interviews across those topics and subtopics. So we should have more possibilities for comparability between the different topic headings. In a semi-structured interview, what we're doing essentially are encouraging respondents to give full responses to specific open-ended questions. Can you tell me what you think about the availability of drugs at the local clinic, for example? The interviewer still decides the sequence of the questions, and they can digress. If the interviewee gives a response which naturally leads into a new question, which covers something which hasn't been covered in the list of open-ended questions, then it's perfectly up to the interviewer to add additional questions, extend the range of questions that are being asked if something interesting comes up. It's more focused, and therefore it again should be less time consuming, and there should be considerably more comparability between interviews, because here you're asking the same questions, and you may indeed be able to count different types of response, for example, so response frequencies, classifying different kinds of responses under various headings and counting up how many people said this, how many people said that, how many people seem to have this kind of attitude, how many people had that kind of attitude, and that can be used in analysis. This approach is less dependent on interviewer skills because you have worked out reasonably complete open-ended questions before you start the exercise. So you spent quite a bit of time. That of course makes it rather more difficult to design these questions, because you're getting back to the questionnaire dilemma that before you go into the interview phase, your concepts, your definitions may be quite problematic, and you may find that they don't work terribly well when you start dealing with particular kinds of respondent in particular locations with particular kinds of views on the world. So the flexibility of interviews declines as we move from the conversational to the topic focused to the semi-structured forms. And obviously the next step in this process will be to close questions and a questionnaire format, again reducing flexibility. So there is a trade-off. That trade-off can limit the scope of the responses. So if the interviewers restrict themselves too strictly to the questions provided, then we can choke off some of the possible opportunities for serendipity, for unexpected responses, for interesting answers that don't fit into the expected range. So what are the advantages and disadvantages in this case? Well, interviewing is obviously we're gaining both insights and we're getting context. The interview can describe what is most important to themselves. So we're not imposing priorities on the respondent. We're asking them what they think about a particular issue, and they have the freedom and flexibility to describe that to us. Interviews are particularly useful in gathering quotes and stories. So quotes, particular examples of the way in which people were treated, the way in which they had to struggle in order to gain access to a provider, the difficulty they had in raising the money to pay for treatment, and so on. All of these can be extremely useful as a way of illustrating and providing evidence as to the situation in which an intervention is taking place. Again, I remind you about the risk of bias. We have to be rather careful that these really interesting stories are not all outliers, and that we're not emphasizing the exceptional cases rather than the majority of cases. Very tempting to pick on the exceptions and forget about the people who are managing reasonably well. Disadvantages: there is an interviewer bias. Interviewer bias is the thing we try to eliminate in sample surveys by being extremely rigid, by being very inflexible. As we introduce flexibility, as we allow the interviewer to control the flow of the questions and the way in which the interview is pursued, then we make ourselves more susceptible to interviewer bias. Highly dependent on the cooperation of the interviewee, whether the interviewee is willing, able, has the presence of mind to deal with the interview in a reasonable way, is not totally baffled by what it is we're trying to do. And sometimes interviewees try to be extremely helpful, and that's very bad from the point of view of the interview. They want you to have a nice time as an interviewer, not tell you about all their problems and the disagreements they've had with the providers and the insurance companies and so on and so forth. Highly dependent on the expertise and skill of the interviewer, and how much time people have spent thinking about how they're going to conduct the interview, where they're going to conduct the interview. Are they going to conduct the interview in the presence of other people? Is there some way in which they can take somebody out of the household context? When are they going to visit? Because that may dictate what degree of privacy is possible for the interview, and so on. Can be very expensive and time-consuming. Again, expensive because you need very good people to do good interviews. Focus group discussions. I said great favourite with my students because they think this is an easy way of doing research or evaluation, and they think they can get enormous amounts of information out of focus group discussions. That, I would emphasize, is definitely not true. Focus group discussions should be used to explore a very specific topic, a very well-defined topic, with a number of small, carefully selected groups. When I say a number of groups, it should be a reasonably large number. Focus group discussions were first developed by market researchers trying to look at the sale of products for companies. And it's quite common for a market research agency to undertake 40 or 50 focus group discussions to provide information to a company about the potential market for a given product. Very often in the kind of work we undertake, we do 2, 3, 4 focus group discussions, and then we write a chapter describing all of the amazing things which came out of those focus group discussions. Focus group discussion is maybe 8 people, so we're talking about 48 people giving their opinions. Some men, some women, some older, some younger people. It's much less persuasive than if you can undertake a serious number of such discussions, depending on the resources that are available to you. So we shouldn't get carried away that this is a cheap and easy way of gathering information. You need at least 2 people, so we need a facilitator who manages the discussion. And this should be a discussion. This is not a question and answer session. If it deteriorates into question and answer, then it's really not going very well. It's about managing a discussion between the people who are gathered together in the focus group. They should be basically talking to each other with occasional inputs from the facilitator who is managing the discussion, not asking questions. The facilitator is trying to lead them towards a short list of subtopics and try to encourage them to exchange their views around the table on those particular subtopics. And you need another researcher to take detailed notes and, if possible, record the discussion if the members of the focus group allow that. Best practice involves the use of multiple groups. Certainly, multiple groups also means that you probably, in many health service evaluations, want to have multiple groups of men, multiple groups of women. Maybe you want to have young mothers as a group, and then you want multiple groups of young mothers. So it's not a case that you have multiple groups that are quite distinct from each other. You want some degree of repetition to get verification of key findings. You don't want to base all your findings on the discussion in one focus group, in one village, in one location, as many people do. So interaction between participants is key to this, and that's what should be encouraged. And you invite people to contribute to the discussion, and you invite people to agree or disagree what other people have said. And you try to bring all the members of the focus group into that discussion. So facilitators ready to guide the discussion, ensure that everybody has at least the opportunity to make their views known. So sometimes this means shutting some people up very politely and encouraging the silent people to contribute to the overall discussion. The selection of focus groups is extremely important. We're looking for 6 to 10 individuals so that the situation is controllable. Even 10 is rather large to manage if this topic is important to the people who are taking part. But you do want a minimum number, such that you do get a discussion. If it's too small, then the discussion can dry up, and you find that the interviewer, the facilitator, is taking over. This is probably the most difficult part to fulfill. The group should be homogeneous in terms of occupational and social status. You don't want some individuals to feel that they're less knowledgeable or less important. I've come across focus groups where people have, for example, included members of the hospital staff, and they've included senior consultants with junior doctors and nurses. That's not a good group, because people will either be subservient to their superiors, or they will feel antagonistic towards their superiors, and it's not a good basis for the kind of discussion that we're looking for. This rule is almost impossible to fulfill. It's the one that is fulfilled by the market research agencies, because the market research agencies will deliberately go out of their way to pick people who don't live close to each other. They'll come into an area and they'll telephone people, and I know this because I've been on one of these focus groups. They will deliberately try to pick people who do not know each other, because they don't want people forming alliances within the group so that other people feel isolated and feel that the group is being run by 2 or 3 friends. Very hard to meet that requirement in a lot of the work that we do. Researchers should decide the extent to which diversity should be reflected within a focus group. Should we have men or women? Should we have older people and younger people? Should we have people of different ethnic groups? Should we have people with farmers and livestock people in the same group? It depends on the situation and up to the researcher whether the extent to which you form separate groups to conduct your focus group discussions. Advantages, well, they can be efficient, so these sessions usually last 1 to 2 hours. People get very tired after 2 hours, and you can gather quite a lot of factual information, perceptions and opinions from 6 to 10 people. That's a lot quicker than doing it on a one-to-one basis. You may find that if somebody quotes some piece of information which you might have accepted in an interview, that will be challenged in the discussion. My note here, though, is that you must be careful not to assume that the majority of view is necessarily correct. It may be that one person does have inside knowledge, they do have special experience, and they know that in fact sometimes a certain provider does take bribes, contrary to what all the others think. All the others who regard that person as a really nice provider who never takes bribes. So we must be careful not to dismiss minority opinions. In some cases, people may be more willing to express themselves if they're with others who are sympathetic to their position. People may not wish to complain about the service that is being offered to them on a one-to-one basis. They may feel that you may tell the provider who they're complaining about. If they're in a group and one of them starts to complain, other people may well join in and say, yes, I had a rather similar experience, and form alliances where they feel rather less defensive about expressing their views about bad things that are happening to them. It's also possible, of course, that people don't like being in a minority, so that when they're with 7 other people who have opposing views, people may just keep silent. They don't want to stand out as being the troublemaker, the person who stands out from all of the others. So we get that balance there. Disadvantages, it is susceptible, just as interviewers are susceptible to interviewer bias, so FGDs are susceptible to facilitator biases. The facilitator has a great deal of control over how long things take, which individuals are invited, and the quality of a facilitator in a focus group discussion is extremely important, and poor facilitators will produce very misleading information. Discussion can be dominated or sidetracked by a few individuals. You would like to screen the individuals and have an idea, but that's often quite difficult to do. You don't recognize that people are going to be domineering before you invite them to join the focus group. The analysis, as again will be discussed in future sessions, is very time consuming. And needs to be very well planned in advance. As I said earlier, you need to focus very clearly on a particular topic and a few subtopics. Don't make these too wide-ranging, otherwise you won't cover the ground and you'll end up with a lot of information that you won't be able to analyze. this should not be seen as producing information valid at the individual level. You're trying to get it's a discussion, and you're trying to get general opinions. What do mothers with young babies feel about the services being offered to them? You're not trying to find out information about individuals. That's the role of the individual the interview. And you shouldn't assume that the information you're getting, even though you find it quite fascinating and very convincing, it need not be representative of other groups. You really need to have a range of groups and a number of focus groups within each of those categories in order to get some idea of what might be the representative views of different types of people. Okay, finally, let's think about some of the activities that come under the rapid appraisal heading. And I group these in my work under two general headings. One is visual description. So drawing maps, village maps, where the people live, how many people live in each household, how many households have children, what ages of the children. You get a lot of information about the demography of a community by using mapping activities with community members. You can even, to some extent, get an idea of how many poor households there are in a community based on the community's assessment. Where are the people who really need assistance, for example? And you can also get maps about the location of providers. Where's the nearest market where you can buy drugs? Where's the nearest clinic? Where is the nearest hospital? How far away is that? By whatever means of transport is available to people in this community. So you can get a lot by drawing these maps on the ground, on large sheets of paper, and talking about them, conducting interviews while you're undertaking the mapping process. Seasonal calendars, what's the year like? You usually going into a community at one particular time of the year, and there is a tendency among researchers to go into communities at good times of the year, when the weather isn't too bad and when the roads are reasonably passable. So we tend to do a lot of research at some times of the year and not other times. So it can be very useful to have a picture of what the year looks like for the people who are living in a particular place, and the times when they have specific problems. When do they get fevers? When do they get diarrhea? When do they suffer from malnutrition? And then timelines, ones that I use quite a lot. Timelines about health-seeking behavior. When did you first notice you were ill? About how long after that did you try to seek help? How long did it take you to get a diagnosis? And by drawing a timeline, marking on the timeline when various things happened, you can get a picture of the healthcare seeking behavior of people in a population. Again, alongside an interview about the problems of healthcare seeking in that particular locality. And then one that I've used fairly recently, the effects of chronic illness. Once your hypertension became very disabling, what happened to your household livelihood? Did anybody help you with that? What were the costs involved? How did you manage to raise the money to meet those costs, and so on and so forth? All of this along a timeline. The last year, the last 2 years, since your illness started, since this festival, whatever. And it's two functions. One is to pin down the time gaps, how long it took, for example, to get a good diagnosis. But the other one is just to provide a basis, an activity during which you can have an interview which discusses how these processes work. And then organizational charts. What's the village structure? How do the committees work in the village? Who are the powerful people in the village? Who do they talk to? What are their links to the higher authorities, and so on? And then health service networks. What's the process for using the health system here? Do you go straight to the hospital, or do you tend to go to the clinic first? And how does the clinic link up to the hospital? are the clinic and the hospital in competition, as in many parts of rural China, where I've worked quite a lot, or are they actively engaged with each other? What are the true lines of communication, and how is there oversight from facility as far as people in the community know? So various types of organisational charts showing lines of communication, lines of authority, lines of oversight. Second group of rapid appraisal activities that I use, diagrams and activities of one kind or another, local indicators, very standard within the rapid appraisal repertoire. What is it in this community that marks people out as being poor? What is it that defines the quality of providers? How would you choose a provider? How would you rate providers? Grouping of providers, stratification. How would you group the people in this village? What groups are there? How do they? What are the criteria on which people fall into different groups? Ranking. How would you rank providers in terms of the way in which they treat you? In terms of those qualities you've already told me about, how you assess the quality of providers. How would you rank the various providers that are available within this area? And we can rank them in one dimension, or we can rank them in several dimensions. So maybe the public clinic is rated rather highly on technical competence and very lowly in terms of the way in which they treat patients, their courtesy towards patients. So we can arrive at a two-way ranking or a three-way ranking, or however complicated we want to be. And we encourage groups of people in the community, maybe an activity linked to a focus group discussion, for example, to undertake these kind of rankings. How many points would you give to this provider, to that provider? Which order would you rank people in? We can construct bar charts and pie charts with community members in the village, on the ground. How do you use your time? How much time do you spend per day on various activities? If you've got a chronic illness, can you show me how much time you can spend in the field, and how much time you spend having to rest? Can you show me how your expenditure divides up between healthcare costs and other kinds of expenditure? And we can use stones. We can use shells. We can use real objects to draw these diagrams and allow people to allocate different numbers of tokens to different types of expenditure, to different times of time allocation, for example. And we can go to decision trees, another very common procedure. When you get sick, who is the first person you would go to talk to about it? Maybe it's somebody within the household. Having talked to that person, what other people might you be able to go to? How would you decide whether to go in this direction or in that direction? What are the chances? What is the probability of you going to this person or to that person? And so on and so forth. So we can draw out quite complicated trees linking different decision points about healthcare seeking behaviour. So here finally is a village map from one of my colleagues' exercises, and you can see here each of the households is listed, and we've got, for example, users of family planning, adopters of family planning, what kind of latrines they have, and we have a number of people living in each of those houses drawn alongside. So this can become quite elaborate. This is a fairly small village and therefore relatively manageable on this sort of scale, and we get a fairly comprehensive, notice it's a quantitative picture of the village produced by a qualitative activity, accompanied by an interview which will draw out information about maybe why some people live in some locations and other people live in other locations, where the important people are in the village, and so on and so forth. As an example of a timeline which I used fairly recently, this was asking people over the course of the year to provide details of how their illness progressed, and so this person started getting severe back pain which limited their farming abilities, went to the village health station after suffering for a couple of months, no real result from that. Condition got worse, had to give up farming activity, and the son had to come home and help with the family farm. Eventually the person's condition deteriorated even further. They were probably bedbound and had to go to the township hospital. As a result of that, had to borrow money to buy the drugs recommended by the hospital, and they improved somewhat, but then they went right back downhill again by November, and but then they went to the county hospital. Maybe they had some money from a relative to go to the county hospital, and their health improved by the end of the year. So here's a timeline, and we've got very basic stuff here. But what we can do through an interview process and getting people to talk through this timeline, we can maybe gather information about how much the county hospital cost, how much money they had to borrow, what kind of drugs they were prescribed, what degree of support they got from neighbours at various points in time, and so on and so forth. So it's basically a process of constructing this kind of timeline. And this one was done actually with the household taking part, and various members discussing when certain things happened and correcting each other about the quantities and dates, until we leave the household with a fairly clear picture of this person's experience over the course of the last year.